So the topic is, I should put local governmental public health ethics committees, because I'm speaking as a public health official here. So we'll go through the learning objectives are, we're going to talk about some of the ethical challenges that we in local public health, actually our state partners face some of these as well. Um, Given that, well, I'm going to describe the practical aspects of putting a process in place, an ethics process in place to address these challenges and actually help us make better decisions related to those challenges. I'll talk about some of the factors that are associated with success, having a successful committee, and having community input and stakeholders. I'll hammer that in a bit, and then we'll talk about the effectiveness of having an ethics committee or an ethics process in terms of, especially what we've seen around public health recently in terms of trust issues. The effectiveness of having committees in a process like this in increasing transparency and building trust. This is the outline. I'm not going to read it. I'll go through all these. I have a lot of slides. I'll try to get through this in time so we have time for discussion. But this is what the outline is. And first, I'll talk about public health. So, as opposed to clinical medicine, it's everything we do as a society to ensure the conditions that everybody can be healthy. And what I do in our, governmental public health is just one part of a system. And I'm going to be talking about governmental public health here a lot in terms of that we have responsibilities based on state laws. Actually, health is not in the U.S. Constitution. It's part of I hate to use the term police powers of the state, but it's granted to the states. And in addition to the state authority, we also have local ordinances that we have some responsibilities around. And then I'll just mention the latest version of public health is Public Health 3.0. There's a link there. And we mentioned in the previous excellent talk, we heard about social determinants of health. And actually, Public Health 3.0 talks about how, in working with community partners, the new version of public health really is associated with addressing the social determinants of health. I don't like the term chief health strategist. I like the term community health strategist, but that's how the reference is describing it. And the evolution of public health from the late 19th century was knowledge, the sanitary revolution, knowledge of microbiology as well as sanitation. Then we saw in the 20th century development of public health departments across the United States. But the focus is limited to traditional public health programs. And Public Health 3.0 is now we do this community work, and we actually our role, a big part of what we do is addressing the social determinants of health. So dovetails nicely with what we heard earlier. We don't do that by ourselves. We do that through our partnerships. So public health ethics, and if you've heard this before, let me know, and I won't rehash it, but basically it involves the principles of the values that we have in practicing public health, the specific problems that we address in our daily work, the procedures that we'll talk about in terms of how we address the ethical challenges that come up, and then how we actually apply this in practice in planning and decision making. These are some of the core values. Some of this comes out of the original Public Health Code of Ethics developed a couple of decades ago by the National Public Health Leadership Society. But around health, humans have a right to resources. The goals of public health are protection, health promotion, and prevention. And you can see the associated principles around equity, getting to the root causes, respecting community member rights, Values around community, that we're inherently social and interdependent each other. We're not individual islands. We're actually interdependent with our physical environment as well as other people. We can't do our work in terms of without the public's trust, and we saw how difficult that has become during the pandemic. We work in partnerships and collaboration, and everybody has an opportunity to contribute. And you can see some of the principles, some of the appropriate associated principles there. We are based on core values on science. It's the basis for much of our public health knowledge, and people are responsible to act on what they know. We also, in terms of some of our principles, have an obligation to respond to issues that come up in a timely way, and we have a responsibility to ensure the competence of our public health practitioners. I don't want to read all of them. I think it's and you all have the slides afterwards. I hope I'll be happy to share them. I just wanted to briefly review the difference between clinical ethics and public health ethics. So the bottom line on this is that public health really is population based, as in terms of in clinical ethics is more patient based. It's like the focus is on populations and not on individuals. So clinicians have fiduciary relationships to their patients. We in public health are public stewards. We're oriented towards prevention. And by the way, these are not mutually exclusive. They all, there's overlap here. Clinical clinicians are associated with treatment. Where main focus is on prevention. Clinicians are focused on individual benefit harm. We in public health are functioning on a net social good. I already mentioned the interdependence of people in public health, and clinical medicine is more oriented towards autonomy. Authority in medicine is vested in the medical profession and physicians, whereas I'll talk about this in a minute, in public health, have the authority vested in the police powers of the states. In clinical medicine, is not always, but law sometimes is more of an adversary than an ally, whereas in public health, it's a key tool that we use. We work to obtain societal consent, where clinicians obtain patient consent. Clinical clinicians are oriented towards doing the right thing and not doing harm. Our focus is on social good and avoiding social harm. And we already talked about access to care related to justice and clinical ethics, and we're about social justice and equity in public health, but certainly there's overlap. I just want to mention, I already brought up the police powers. It is key to what we do. Some examples are communicable disease investigations, requiring vaccination as a condition, excluding, for example, children and staff from school if they're not immunized during an outbreak of vaccine preventable illness. We can restrict people's movements by isolating them and quarantining them. We can actually seize property, and we can do things like put in place smoking bans, beverage restrictions, things like that. There are constitutional limits on what we can do. You may all be familiar with Jacobson versus Massachusetts, when there was a smallpox outbreak and individual refused to receive the mandatory smallpox vaccine and went to the Supreme Court. But the court held that requiring vaccination is a legitimate exercise of that police power, but there were limits to it based on the necessity. Whether there was a reasonable means, that means that did we have a vaccine with limited side effects? Did we use the least restrictive means of protecting public health, where proportionality comes in? and harm avoidance. We should not impose an undue health risk on people receiving the vaccine. I think you've seen this all play out with in the discussion that's going on around now around the COVID-19 measures that we took, as well as vaccination associated with that. The law tells us what we must do and what we can't do, but it doesn't tell us what we should do, and that's where public health ethics comes in. And the law sets a foundation or basement. Ethical public health ethics is more aspirational. With the law, there can be punishment for violating the law. That doesn't happen often around ethical violations, although some ethics are, become law. But ethics is more aspirational. The law provides authority and limitations. It's more formal. And where ethics comes in is it provides an ongoing analysis and deliberation, and it really helps us justify some of the actions. When the law allows us, says we can do something, ethics provides a way of deliberating around what we should do and justification for it at the end of the day. And it's a bit more, it's less formal, and the justifiable positions or measures we take are based on ethical reasoning. Certainly, it helps us prioritize and justify. We can look at if we're faced with a challenge, what decisions can we make, and what actions could we take. Um, it basically, by having an ethics process or an ethics deliberation, we have much greater, especially we involve, and I'll talk about this later, community partners, greater transparency in decision making, and at the end of the day, having an ethics process and in public health helps enhance public trust. We can't do the work we do in public health without trust, and we've seen how that's been damaged over the last few years. It offers, and this is where ethicists come in as well, public health ethics offers a vocabulary and guidance, and including guidance around, public health is certainly interested in utility and, the greatest good for the greater number, but having ethics guidance and vocabulary helps us talk about things like social utility. And as an example of that, if you remember back to the H1N1 outbreak, I think it was more than 10 years ago, we were figuring out how we should allocate vaccines because there was a vaccine available right away. And we decided that we needed, when there was a limited amount of vaccine early on, we allocated it based on social utility. We gave it to the people like the EMTs and the people working in the, first responders, people working in the field, because we needed to have people able to work in the field and provide care. So that was we didn't give it to for example, folks in long-term care facilities first. Our primary allocation was based on social utility. So why create an ethics committee? These are examples of some of the challenges we face. One is how we allocate scarce resources. Vaccines are one example. When they first come in, ventilators might be an example during a respiratory illness pandemic. Conflicts of interest, because we work with public funding and taxes, and we're accountable to the community and the taxpayers. Negotiating the political context and dealing with political challenges that come up. It shouldn't be, but unfortunately they do come up. How we use data in terms of privacy, and how we look at balancing autonomy, individual liberty, with protecting the public good. So those are the typical challenges we face, which are somewhat different than what we see in clinical ethics. In terms of creating an ethics committee, and I'll talk about that work, and I wish we had, in the amount of time we have, I would have gone through some cases. I'll talk about cases briefly, but if we had more time, when I do this, I generally do a 2-hour workshop where we actually form an ethics committee and we deliberate about a case. But I'm going to just provide more, basically, I'll present some cases, but with the results of the deliberation. But first of all, you need to have an ethics champion, and leadership of the health department needs to be supporting this, and they need to be trained in this. Staff needs to be trained. We need to train committee members. We have community members. In fact, more of the members of the ethics committee are from our community partners. Develop a charter and framework, and then begin deliberating. I'll talk about all of this. This is what goes into our charter. The link is there. You can take a look at it on our website. I'll talk about each of these. So it's a diverse group, and we do want equity there. Racial equity, for example, is a core health issue that our department is addressing. We want a diverse group of volunteers who provide guidance on ethical issues, and this includes some of our staff as well. Support an institutional culture. This changes the culture of our organization by having this process, and provide an open and transparent decision-making process. That's the purpose of it. The ultimate goal of this is to make better decisions and build community trust. Some of the things that are in our charter is a way to determine if ethical dilemmas are appropriate for analysis. There's a place on our website where community members can actually raise issues, and staff can raise issues. Members need to facilitate and or participate. We prepare reports. We coordinate reports out. And one of the things you need to do is keep folks trained in this. So if we don't have any cases to deliberate, we'll use some cases off the shelf to keep committee members fresh in terms of doing these deliberations. Our values is on organizational decision-making and policy recommendations and operations. This is not about individual or group behavior. And we make it clear to our staff that this is not about individual ethical behaviors or staff behavior. That gets referred to HR or elsewhere. That's not what the committee does. We use, as I mentioned already, a health equity perspective, and this actually supports a culture that values ethical awareness and standards. The composition is, we have a diverse cross-section. You can see, I'm not going to read the list there. We have organizational membership as well. We require, our committee has either a hospital or an academic ethicist. The county attorney is a member of our committee because obviously the use of authority comes up. Depending on the deliberation, we will bring in ad hoc members. They don't need to be trained. We have a core group of ethics committee members who are trained in the deliberation, and we have the framework we use, but we will bring in key stakeholders, ad hoc stakeholders, as well as key subject matter experts. And I'll give you a couple of examples of where we've done that. And also we involve our staff that may have key information. We have a facilitator. We have the attorney. I've already mentioned that. The ethicist can help provide guidance, including conceptual guidance as well, and guidance of the ethical analysis. And I've already mentioned this already, so I'll move through this slide quickly so we have time for questions. And I've already mentioned what the committee members do. We use a consistent framework, which I'll share with you. The committee recommends a course of action to public health department leadership. And the department leadership will respect and strongly consider the committee recommendations, but we let the committee know ahead of time that we're not ceding our authority to the committee, but we're going to strongly respect and consider what their recommendation is. We have the ultimate responsibility around the final policy decision, but we will communicate our rationale with the committee when we do so. The other point I've learned about this is, well, first of all, we inform the committee members in advance, but the process is actually as important, if not more important, than the outcome when we're making these decisions. We have some ground rules. I've already mentioned that personal issues are referred elsewhere. And if somebody is absent, they'll respect the decisions, but we can reconsider it if we have some absent participants who strongly object. I already mentioned that we don't cede our statutory authority, but we'll respect the recommendations and we'll communicate the results back to the participants. We use a case-based approach to guide ethical analysis, and we include in our group deliberations involve listening, asking questions, challenging each other with respect, and it's a transparent process. I think you're all aware of the case-based approach. We've already discussed that. There's the story part of this really helps with reflection and discussion, and allows us to consider different perspectives. I'm going to give you the other thing I want to point out is a key point about this is to making sure that you're inclusive, that we're inclusive, involving all the stakeholders. This isn't a battle between good and evil. We're balancing moral perspectives and moral values that stakeholders have here. And ultimately, in the end of the day, if we're inclusive and we consider the moral claims of all the stakeholders potentially involved, we build trust and acceptance at the end of the day. People may not agree with the final decision, but they can certainly understand the process and build trust there. It's deliberative. We weigh the values and we choose. At the end of the day, we have competing alternatives that we can choose between. So I just gave you I threw this example. I don't know if you've seen this one before, but this is a example of how stakeholders may have different points of view. So if you're the health director and you have like 100,000, some money, you get a grant to purchase a car seats, and you have a choice between the economical car seat, user-friendly car seat, which is a bit more money, but it's more user-friendly. And then you have the ultimate reliable car seat, which isn't not as easy to use, but not that hard to use, but it has the highest safety rating. If you're the health department official, which one are you going to choose and why? And how might there be different stakeholders? I don't know whether we have a chat here. I don't see a room for chat. Is there?
There is
you
a
can
chat.
Just speak up.
No, there is a chat.
Right there.
What do you think? Which one are you going to choose? You get the most. You get them. If there's a shortage of car seats, you get the most car seats with the economical version. You as a public health official, what are you going to choose?
Well, I think I would aim for the middle one, right?
And why would you aim? And what other stakeholders do you think would aim for the middle one?
That's I think anybody who's going to think about how to get this out there to the vast population, it's going to be user friendly, and yet I'm going to save $25 from the top model.
Yeah, so I'll just cut to the chase. This is maybe not the best example, but parents may be the ones who are in favor of the user. If you get a bunch of parents in there to the deliberation, they may say, we really want, something that we can use easily. The economical one, that the health official might want that because they can get the most kids, it's the greatest good. The reliable one might be the engineers in the group that, they think that there should be it should be the most effective one possible. So it's just an example of how there's no right or wrong answer here, and there generally isn't. But the idea of this is that different stakeholders may have different. This is a kind of a silly, simple example of how stakeholders may have different opinions and values about what course of action to take. Okay, so here's the step one of the framework. And I like to actually start with the public health goals. And I'll give you an example. I usually use a TV example, but for this one, I'm going to talk about something that's happening right now in Clark County with the city of Vancouver. And the issue is around uh, food, providing food for unhoused populations. We got a number of churches and other community groups that are providing food for unhoused people, and they're bringing the food from cooking it at home and bringing it to like the churches and the events. And our environmental public health staff are concerned about the safety of this practice. And we're actually having a meeting with the city and the mayor and I have had ongoing discussions. And this would be, we haven't gotten our ethics committee involved in this, but just to give you an idea of what might be on the table there, if they're thinking about the public health goals, what do you think the public health goal, in terms of, we have these uh, uh, events or these places where unhoused people are getting food. What do you think the goals might be? There are different goals here. I'll just cut to the chase because we will run out of time. So one of the goals might be to deal with hunger and make sure that people who are food insecure actually have an opportunity to get food. But another goal might be avoiding communicable disease and avoiding a huge foodborne outbreak in a population that has a lot of comorbidities, not the greatest health status. So you need when you have this deliberation, you have your stakeholders, you start thinking through what the goals are. And it's not because there may be a right or wrong answer at the end, but the answer or the intervention that you do or the decision you make will take that into consideration. You think about what are the risks and harms of concern, what are the hunger, food insecurity, as well as foodborne illness. Who are the stakeholders and what are their moral claims? It's key to get and that would include the people providing the food, our staff, people who are unhoused, people who work in programs for unhoused people. Do we have the legal authority to shut these down? Um, uh, we probably do if we consider there's a health risk. But when we already talked about least infringement, and I'll get to that in a minute, is there a historical context? And do our professional codes provide guidance? But that's just an example of what would be. We're actually getting into. We almost did a deliberation with the free fridge program. I don't know if you're familiar with that, but we can talk about that if we have time at the end. And then so whatever we decide to do here, and I can tell you where we're at the end of this if we have some time. But does it what's the balance between benefits and harms here? Are they distributed fairly to people who are involved in this? Do the stakeholders have the opportunity to participate? Do we respect individual choices and interests while considering the impact on the community as a whole? And does our action respect, the people we're interacting with, the professional and civic roles? Does it, are we building consensus? Is the process transparent? Do we predict in talking about how we're providing food for the homeless? Does it protect communities from undue stigmatization? One concern I have is that, just because you're unhoused doesn't mean you shouldn't have the right to the same safety of food as other populations. So those need to be taken into consideration. And then in step 3 is if you come up with a recommendation for public health action, is the goal likely to be accomplished? Will the benefits outweigh the moral considerations? Is it necessary to override some claims to achieve the goal? Are we using the least restrictive and least intrusive method possible? And at the end of the day, can we provide justification for our action? I'll just cut to the chase. This has not gone through our committee. I wouldn't mind it going through the committee because I think we come up with a better answer. But what we're probably going to do is we're not going to shut these down. We're not going to sanction these events, but we're not going to give them the gold star of approval either. And we're going to work with them and work with the people bringing food to provide them as much information on how, you know, they can reduce the risk and improve safety. That may be where we end up. That's just an example, but it would be a good one for the ethics committee. You know, we haven't done it there yet. This is just a summary of what I talked about. There's a new updated code of ethics, and I put the link there, and it includes these core values and obligations. I'll briefly mention them. Would an action be ethically wrong, even if it were to have a good outcome? That's permissibility. What would it be? Would it be demeaning or disrespectful to communities or individuals, even if it improved their health? What have we done to upset the potential harms and losses that proposed action imposes on people? That, you know, an example on that is around, you know, some of the efforts we took during we've taken during the pandemic. What have we done to accommodate people when we put restrictions on them? If we're, you know, when we were quarantining people in some hotels we had in Clark County, we made sure that we had to provide them with access to care and food and all that other stuff. Is it reasonable to expect that the action would achieve the goals? And are we good stewards of public resources?
And Alan, I hate to interrupt you right this moment,
Yeah.
but there was a question that Molly did bring up earlier on in the chat.
Oh, I
Whether she
can't see the
wanted,
chat for some
oh,
reason.
if you go down to the bottom, you should have a participant and chat buttons, and
Yeah, I'm not seeing it in my little window here. Maybe if I do the grid view, I'll see it.
But so Molly was asking just for a reminder as to why the vaccination was not made mandatory for COVID, and so it sort of feeds in a little bit to what you're talking about here.
I think in certain situations it was mandated in terms of certain professions and healthcare workers, but I think, yeah, that led to we I actually, the question is, why wasn't it mandated?
I think that's what I said, Alan, but actually, I just wanted to be reminded about the thought processes. I mean, you have such a nice framework here, and there is this history in terms of mandating vaccines in the past. So how was it approached from a public health standpoint?
Yeah, I think, you know, we had some specific, I think, you know, we had our partners, for example, healthcare settings require vaccination for those situations. I think this is where we're negotiating we didn't bring it to an ethical deliberation, but I think we would have mandating vaccination for the general public, I think would have been really difficult to achieve. I mean, right now, I mean, we don't. That's a really good question, but I think that given the tension between individual, you know, autonomy and the public good, I think we would have had a difficult time. It made it more difficult given that the most adverse outcomes were in the aging population, you know, people over 65, and that kids, you know, children, even though they could transmit the infection, had a low, not, you know, actually the morbidity and mortality was not that low in kids. It was not nearly what it was in older populations, but we had thousands of hospitalizations in kids and at least hundreds, if not more than hundreds, of deaths in children related to this, but did not have the morbidity and mortality in older folks. And you might have heard all of that, you know, on social media and elsewhere, that I think we would have had a really tough time mandating vaccines, including. I got to really get to the State Board of Health. There was a consideration about whether we ought to require COVID-19 vaccine, mandating it for school entry, and that was tabled. And it was tabled for the reasons, yeah, it was going to come up, but you know, we have a number of other vaccines that are required for school entry. I don't see that coming up with COVID-19 anytime in vaccine in the near future. Hope that's helpful.
It's very helpful. We can talk offline. It seems in the context of this morning's discussion that social narratives in this particular situation played a strong role in determining whether or not to address mandated vaccines or what to do about it in the healthcare setting and the school setting. The social narrative, which was the theme of that last talk, was very different 100 years ago. I'll stop there. Thanks.
Yep. Okay. And then proportionality. This has come up. Accountability, transparency, and public. I honestly, I think we could have done a better job communicating around this, and I think we could have actually had I don't know if I call it a national ethical deliberation, but I think if we had more around the vaccines and vaccine mandates, and we engaged stakeholders and had more of a deliberation like this, we might have done a little bit better. I think a lot of decisions were made without great communication and great listening on this. Okay, so these are some examples that we've had in our ethics deliberations. I'll go through them. We were having the conflict of interest one, our immunization coalition meetings, and included our partners in like school nurses. The lunches are being catered by pharmaceutical companies. So that was one, should we continue that to happen? And you've heard some of the criticism that, public health is in the, we're getting all these gifts from big pharma, and all that. So that appearance of a conflict of interest. Should we participate in this study? It was a RAND study that randomized participants for the Nurse Family Partnership home visiting program. How we should allocate, CCPH is Clark County Public Health, allocate ventilators during a pandemic. We actually did that one in 2017. And then a long time ago, should restaurants involved in the Healthy Restaurant Program be removed if they allow vaping on premises? So those are examples of one. The one about lunches or gifts from pharmaceutical companies, we brought in as stakeholders not only the immunization nurses, but we brought in the pharmaceutical companies as well. And we learned about what we learned that, they were the ad hoc stakeholders. And we learned that they had their own ethics policies, and they felt they were okay with not sponsoring them, but they felt like they were being singled out. So we changed our policy to exclude. We would no longer have immunization coalition lunches catered by either pharmaceutical companies or medical equipment companies, and they were happy with that. That was the ultimate decision. I don't know if I'm going to have time to get into the Nurse Family Partnership study. I think I'll talk about the ventilator one. So in 2017, we decided that in the event, I don't know if it was prescient or what, but in the event of a pandemic, a respiratory pandemic, and not enough ventilators to go around, how would we allocate them? And we convened subject matter experts as well, which were critical care physicians, nurses, and respiratory therapists. We brought them in. They've made a recommendation that we brought to the ethics committee, and then the ethics committee reviewed their recommendations. And the recommendations were that we would develop a score based on their sequential organ failure assessment. That's the first row there. And that's the likelihood that you would make it out of the ICU in the first place. The next one was to save the most life years, and that was based on comorbid conditions. And you can see the more severe they were, the more the higher your scores, and the less likely you would be to get a ventilator. And then there was this life cycle principle about chancing your opportunity to live through the life stages. So that was a recommendation from the subject matter experts, and something similar was in the literature as well. We brought this to the committee. Oh, and then they also said, the other thing is that the treating physician should not be responsible. The decision would not be made at the bedside. We'd have this triage team that was blinded to everything about the patient accept these scores, and it would include the members that you see there. And one team would cover the entire county, so it wouldn't depend on which hospital you showed up at. And that certainly the patients removed from ventilators, so we'd be able to remove as well as put people on, would be offered palliative care. And the triage team would have no access to information. The only thing that they would have access to is the scores that I talked about, and we'd be explicit about this is, I'm sorry, this is the point. This is when we brought it to the ethics committee, and they made their first point was about what the triage team should have access to. And also the scoring system should be more explicit by was meant by major minor comorbidities. They were concerned about racial equity, equity in terms of some populations are more likely, based on, again, the social determinants of health, to have comorbidities. So we would be perpetuating racism by accounting those in that way. So this is what they came up with. They eliminated the the mild comorbid conditions from the scoring scheme because they thought that that contributed to inequities in terms of who would get a ventilator. So they basically changed the recommendations that the subject matter experts had come up with. And then we also got feedback from faith leaders, and we also talked to home ventilator users as well. And at the end of the day, it seemed like a fairer process, and there was more trust in terms of doing that. I'm not going to go. I think we're going to be running out of time here, so I can come back to this if you want to hear about. Oh, I'll just be really brief about this. When we did the issue about the healthy restaurants and the vaping process, we not only brought in the restaurant community as stakeholders, but we brought the vaping folks in, the people who sold vaping materials. Turns out they were okay about not having it in restaurants. They didn't want to give vaping a bad name when somebody eating in a restaurant would be smelling popcorn vape next to them. So that one worked out pretty easily. Okay, I'll go through the summary and then I'll be happy to answer questions. So first of all, in terms of making these successful, you need to have buy-in and support from leadership. You need an ethics champion, and the health department has to provide resources. There needs to be a common understanding between members of the ethics committee and department leadership about the idea is to help us make decisions, but not to address staff or performance issues. That the health department will not cede its authority, but will respect and strongly consider the committee recommendations. You have to include a process that helps you recognize ethical dilemmas appropriate for analysis. So staff can bring and community members can bring issues to the committee. That was the issue with the free fridge. I don't know if you're familiar about free fridge. Have you guys heard about that one? So free fridge it's a movement. People can put refrigerators in their yards and stock them with food for people with food insecurity can come by and get stuff out of the fridge. And they monitor them. They have volunteers look at the temperatures and monitor them and all that. People are putting home cooked meals and leftovers into these fridges. Our environmental health folks went out, our restaurant inspectors went out and saw some of these, and they raised the issue about should we allow that practice to continue. So we had almost put a deliberation together. We were going to invite the free fridge folks in as well. We ended up with a lot of community interest. I think we had like 60 people wanted to participate in that deliberation. And we put it on hold because we were dealing with the pandemic at the time, and we just didn't have the bandwidth to do it. But we may consider doing that again. But you have to have a process where people can recognize and bring issues to the committee. We should provide reports that describe the analysis, the recommendations, and we need to share those. We come up with reports and outcomes, and we did that for the examples I have already given to you. You have to have a process for recruiting and training people. So there's a bunch of And I gave you some resources at the end of the slideshow, but there's a bunch of resources. There's even case books. So if you want to practice cases and, make a mock, have your ethics committee do a mock case in between the real life deliberations they're doing to keep them fresh, you can do that. I mean, here's some examples of what we've come up with. So should the health department exclude unimmunized or underimmunized children from school during a pertussis outbreak? That's an example, of mandates and, vaccination. There was a case about a community where more than about a third of landlords owe more than their houses are worth, but they're housing people in these houses. And should they get an extension to remedy lead paint hazards if otherwise the homes will be condemned and the rent will lose their housing? This has actually come up in other situations. So you're balancing the risk, around lead paint hazards with being unhoused. That's come up with failing septic systems as well in real life that I've had to deal with. I mean, so that's another example. And one that I've used many times in training is, should we require directly observed therapy for drug-resistant TB, tuberculosis in a child when the parents insist on self-administering? And not requiring directly observed therapy could result in challenges around managing that patient, as well as risk to the community from multiple drug-resistant TB. This is where, looking at the goals come in, when you're requiring something like this, or your goals, there are goals related to the health of the child, parental autonomy in the family unit, not disrupting the family, but also the greater good in terms of preventing risk to the community of drug-resistant TB. So we have that case to work on as well. Ultimately, the ethics committee and its framework are tools that help us make decisions. I already mentioned the process is at least as important as the outcome. The idea is ultimately to build community trust, because we can't do the work we're doing without community trust. And it's really a small investment on the part of the health department. The biggest mistake I've ever made, and well, I've made a lot of mistakes, but the biggest mistake is missing key stakeholders. And even on individual, that issue around, I just talked to you about TB and directly observed therapy. I thought I had the family agreed. I went out and went out to the home, met with the mother. She seemed agreeable to it, and then the family refused. And, it's just an example where I missed a key stakeholder who was a father, who in that situation made all the decisions for the family. So missing key stakeholders is something you don't want to do. And the case approach can inform our health departments dealing with similar issues. So we share the results of this with other health departments. There's more information. Wow, I am getting done. Only 10 minutes of time for a question. So we have our information on our ethics committee. The National Association of County and City Health Officials has a ethics website. There's training materials there. CDC Ethics Office has it, and then there's information about the Code of Ethics. So I'll stop sharing if I can do that. I don't know how I can do that, because let's see. I have a different. I don't have a choice at
So,
the
so up
bottom
at
of
the
this.
top, Alan, you should be seeing a stop button, or there should be some sort of a little bit of a menu up at the top that you're going to
Yeah,
see.
I've got grid view, active speaker, and active speaker view. There's also a closed video window. What would that do?
No, that's just going to
That,
close you probably. So, but
this is interesting. Let me see. Show me video settings. I was worried about this. Yeah, I don't have that. Once I shared my screen, it
yeah.
stopped me from having that
Well,
box.
I think so we're open for questions, folks. What questions do you have?
Oh wait, now I'm getting it. So I stopped sharing. Okay, I got a thing on my.
So it looks like Rachel has a question. Why don't you go for
Sure.
it, Rachel?
And I can see the chat now, by the way.
Yeah, hi. Thank you for your talk. I really appreciate like the other side. I've not worked in public health. I've been all acute care. So I appreciate hearing the other side of it. But as a community member and kind of healthcare adjacent, what's a do all public health departments or all counties have a public health ethics committee? And how can we stay apprised of our kind of local sectors work or be involved in what's going on in my community closer?
Where are you located?
I'm in Clackamas County. I
Oh,
work
well, you know,
in
I know,
Multnomah
so I'm
County.
in Clark and I know the Clackamas, and I've actually trained some of the surrounding counties. And so I believe Clackamas has a ethics committee. I'm pretty sure they do. So I'm trying to remember the name of their director because I know him really well and I'm having an aging moment right now. But they have, is it Philip? I think it's Philip. They have an ethics committee. Multnomah County has an ethics committee. I'm pretty sure Washington County has one as well. And you can, I can, you know, if you send me an email, I can give you the contacts over there. My email is Alan, ALAN. I can put, I'm almost positive that they have one because I went out there and helped them get it going, I believe. I'm losing my mind now. And I'll put you in touch. I'll copy them in and get you information on that. No other questions. You all know how to do this. Are there any issues that you've thought of or?
One question I wondered about, Dr. Melnick, and I know Molly, maybe she's popped off, but like the infrastructure or the approach you take, whether you coordinate with other health, because I'm trying to remember the scope. Is it the county level scope that you have for public health?
Yeah,
Or
so we work out. I Our public health department is Clark County, so it's the
yeah,
entire county. So
I was on the part of the group that was the different hospital systems during COVID, trying to work with crisis standards of care standards. And we were trying within hospitals to come up with a similar plan. And I know Molly Osborne was part of that. And it was challenging. But the guidance we had is if we, could have more of a unified approach, even with the Oregon Health Authority, then that, there's sort of less risk there, I guess, of having a approach that's kind of vetted and standard. And I wondered what your thoughts were on that, if that's
So when we did that, by the way, I'm on the PeaceHealth Southwest board for whatever that's worth. So, and I'm a member of the PeaceHealth Clinical Ethics Committee, but I haven't had the bandwidth to be able to attend all that. And Prasanna, who's is from Legacy, is actually our Lori Morrison used to be our ethicist on our committee. When she was with PeaceHealth, she left and she went to Oregon. But Prasanna is on our ethics committee, although we haven't deliberated in a while. When we did that ventilator, we engaged with both Legacy as well as PeaceHealth, and so we never implemented it. I think there was some other recommendations were made by our partners south of the river. But we never quite implemented that. But we have the report, and we could down the road. I remember I had presented it to I believe I'm trying to remember it was the emergency preparedness folks at Legacy Salmon Creek. So we were engaged with the hospitals on that. And by the way, besides our ethics committee, we also have representatives from both hospitals on our public health advisory council as well. So we have to engage. There's no way to do this without engaging with the healthcare partners.
Yeah, I'm just appreciating kind of the like that it's slower, right? But you like you even your point of is including community members, but it's also really important to have
No,
those
yeah, you
stakeholders.
need both. You need community members, you need subject matter experts as well as
Hmm.
where the critical care physicians came in.
Hmm.
When we're doing the ventilator thing, we reached out to the AL. I didn't know. I was stupid about this. We reached out to the ALS Association, and I learned that home ventilators could not be commandeered to be used in hospitals. So we figured that one out pretty. But
Hmm.
our original goal was to make sure that we didn't eliminate any stakeholders at all.
Yeah.
Yeah, you have to identify. This is a partnership. And there's sometimes you can convene to make quick decisions, but it's good to do some things like that ahead of time when you have
Hmm.
more time.
Hmm.
Alan, I'm going to bring your attention to the chat where Rachel has asked this question in relation to the houseless and drug epidemics.
Okay, I'm scrolling down. Anything that's difficult to use, I'll have a low. Okay, is it further down? Oh, current houseless and drug epidemics.
Yeah.
Um, were you thinking of a particular question around that?
No, no, not really a question to be solved. I just, as I think about the intersection of public health and
I
like
got one,
community.
actually. I
Good.
just thought of one.
Oh, go for it.
Yeah. Right now, there's a lot of, and it's somewhat related, but you brought up about drug epidemics. There's a lot of controversy around harm reduction. Are you all familiar with harm reduction? So we have a harm reduction center, and actually this came up in Multnomah County. You might recall that issue about safe smoking supplies came up. And I think it would be great to have a deliberation about harm reduction services, including the problem was the way it was implemented. The politics got involved in it. There's so much stigma about the population. Um, I'm sorry, I'm being a little bit scattered here, but right now, we've gotten criticism about our syringe exchange, and not in Clark County, but in some rural health departments, they put real severe restrictions on syringe services programs, syringe exchange. That's a way for us to engage the population, and not only can we provide naloxone, which can prevent opioid overdoses, but we can do HIV, Hep C screening. We do STD screening. It's a way to reach that population, but the attack on harm reduction programs is making that difficult. And also, given the fentanyl and the fact that people are smoking, there's less people coming in for syringe services. That may be enough, if we were able to do safe smoking supplies, if we could have that deliberation, which Multnomah started to do and then drew back, that would help reach that population as well, and also address the stigma. Um, uh, it's a long conversation. I think we think of people think that, you become dependent on drugs and then you become houseless, but it works in the other direction as well, if not more. You become houseless and then the way to get by is to use, to use, and we need to address that. I'm sorry, I'm blabbering, but it would be great for ethics deliberation.